Right. Good evening, everybody. Hope everybody's nice and awake. It's fantastic to have such a good turnout here today for this joint meeting with the LMI and the Liverpool Medico Legal Society. I have to give an apology to start with. Graham Poston, who's the current president of the Medico Legal Society, is unable to be here because of pressing medico legal work. But we do have Nigel Gilmore representing the committee, and he will give a vote of thanks at the end to our speaker. And our speaker, who I'm sure the reason why there's so many people here is because you're fascinated by the topic, is Dr. Gemma Mullen, who's a consultant anaesthetist at Aintree and the Royal Liverpool. Aintree, of course, where I myself work, but also works for the air ambulance service, and so she spends part of her time doing out-of-hospital care with the air ambulance. And what I'm really hoping to learn is how you can deliver that level of hospital care out of a rather fragile-looking flying machine that we see out there. I'm just really going to be impressed by this. So, Gemma, really look forward to hearing what you've got to say. I know you'll be happy to take a few questions at the end, so think about a couple of nice questions for Gemma if you can. Great, and we'll look forward to listening to what you have to say. Thank you.
Thank you. Thank you for the introduction, and thank you for the invite to speak tonight. Firstly, I am aware that there is probably a diverse medical experience in the audience. So this is the first time I've written and done this talk, and I hope it will cater to everyone's interests. I appreciate to some people it will be teaching them to suck eggs, although I'm never quite sure about the etymology of that phrase, because who really does that? But to other people, there might be some slides that you find a bit gory, and I hope it's nothing too much you can't handle. I don't think there's a better place to start than with one of our patients. So let's meet Dave.
The work that the North West Air Ambulance Charity does is absolutely vital. It's a truly amazing service that provides enhanced hospital care for the most critically ill and critically injured patients across the North West, 365 days of the year.
The first time we took me fishing, I thought, well, you did tonight, it was so wow. So soothing, so beautiful. Life's too short. I just realised that it can all be gone in the moment.
The sea was calm. We just fished for too long, fished time and time. Trying to do a retrieval off the beach. I couldn't take it.
I heard the crack, and I felt the whoosh as he flew. I looked down and I could see there's a pool of blood on the beach.
The moment you arrived on base, the moment that you leave, you're on call and you could at any moment be responding to the life or death emergency. We were aware this was an incident in Morecambe, a man that had a serious neck injury after a boat accident. We didn't really have an awful lot more information than that.
When the ambulance crew told me that the air ambulance was on its way, I thought, oh no, it's as bad as I thought.
He got a significant wound to the front of his neck, which was very deep and threatened the integrity and the function of his airway.
His throat was swelling inside because of the impact, so it was cutting off his air supply. He was going whiter and whiter, back to his grey. I was so frightened, but he was so calm.
We knew there was a lot of potential there for this to become life-threatening very, very quickly.
That's a big crisis with people who die sometimes, and I know what death looks like, and there's no doubt what was coming at all.
The course of action which we decided to take was to administer a pre-hospital emergency anaesthetic for Dave. That's to give a series of drugs which render him unconscious and paralysed, and then to manage their airway with a breathing tube, and then mechanically ventilate them all the way to the hospital.
no doubt whatsoever if they hadn't got that squad human on that day. Two weeks after being in intensive care with a broken neck, he's jumping in and out of boats. He's definitely a force of nature.
When you do hear back from patients that they've perhaps been very seriously injured but have returned to their normal life, that's just an amazing feeling. It certainly makes you appreciate just how fragile life can be. It means an enormous amount to the whole organisation to give patients like Dave a second chance at life. This is an organisation that receives no NHS government funding at all, so we're entirely reliant on the amazing hard work and support of all those people.
North West Ambulance service are literally saved his life, so we're not going to waste that opportunity.
I've got the second chance.
Okay, so HEM stands for Helicopter Emergency Medical Service, and what that is a team. And it's a team of somebody who's a consultant in enhanced pre-hospital care, and that's what I do. I work alongside a specially trained paramedic and also a pilot. So traditionally, we as consultants come from a hospital background, and that might be emergency medicine, anaesthesia, or intensive care. But more than that, there's also a huge charity support because, as you'll have heard, it is a charity. We receive no government funding at all, and the charity have to raise £9.5 million a year to keep us flying. And the aim is to deliver emergency and life-saving interventions to patients in their time of critical need. So you may have heard of the golden hour after injury to save someone's life. Well, you'll be aware that that is largely a pre-hospital event. So the aim of the aircraft is to deliver the clinical skills and expertise and equipment to somebody sooner in their clinical course. So we're delivering the specialist input early. And that's why we need an aircraft. Either because the roads are too busy to get there fast, or because the distance to travel is too far. So as a service, we work between 8 a.m. and 8 p.m. And then on Fridays and Saturdays, we work until 2 in the morning. We can only work via air when we can see. So in the winter, when the daylight hours are restricted, we can't fly at night, so we'll respond by car. And equally, if the weather conditions are too abhorrent, as sometimes we do find, then we'll be car-based as well. Now you'll see from these pictures that we have quite a big area to cover. So the North West Air Ambulance serves Cheshire and Mersey, Greater Manchester and Lancashire and South Cumbria. We have 3 aircraft, one of which is the enhanced pre-hospital care aircraft, and that's based at Barton. Now the call sign for that is 72, so that's the doctor paramedic crew. Now Barton is just outside the M60 by the Trafford Centre, and also at Barton we've got 75, which is a double paramedic crew. We have one further aircraft, and that's based in Blackpool, and that's call sign is 08, and once again, that's a double para crew. So why do we need pre-hospital care? Well, injury is the principal cause of life lost in those who are 15 to 34 years, and it's the 3rd most common cause of life lost in all ages. But despite that, it still represents a low proportion of the region's A&E annual workload. So in order to treat the sickest patients with the best expertise, then we need guaranteed repeated exposure, slick pathways, and maintained skill set. And that's why we have major trauma centres. So we have a major trauma centre in Merseyside, and that's Aintree. In Lancashire and the Lakes, it's Preston, and then Manchester, they have Salford for neuro, so heads, and central Manchester as well. Equally, going down, we have the Stoke, which is a major trauma centre there as well. But the paramedics still don't get that guaranteed exposure. Ground paramedics may see 1 or 2 traumas a year, and they're left to deal with these in sometimes the most awful circumstances with the biggest emotions on board, in the dark and in the rain. And when it's something that they don't see all the time, it becomes unfamiliar. So that's why we are there to help support them to get the best care for these patients in their time of greatest need. So how do we get dispatched to jobs? Well, there is a paramedic that sits in the control centre. The control centre is the trauma cell based near Preston, and they screen all the 999 calls. And they screen them to look for mechanisms that are in keeping with a high injury burden, to define patients that might do well with our help. So they might be falls from height over 20 feet, a road traffic crash as someone's been killed in the same vehicle, ejected from it or trapped. 1-unders, what that means is person versus train, and then an amputation proximal to the wrist or the ankle, stabbings and shootings. We also go to some medical patients and some paediatric patients as well, because once again, these are not common things, so we can offer assistance to the ground crews. We'll also go to any jobs where the ground crew request help, and we have a role in major incidents as well. So the aim is to bring to the patients the life-saving emergency interventions sooner in their clinical course. So let's have a look at the type of things that happen on a medical side of things. So bit of anatomy, bit of physiology, getting back to basics. But this is your heart. Your heart is a muscle. The muscle requires a lot of oxygen and a good blood supply to function as a muscle to pump blood around your body. Now, if somebody has a heart attack, one of their vessels has been blocked, and if this is a bad heart attack, then the muscle may stop beating effectively and the heart goes into cardiac arrest. What that means is the heart has stopped beating effectively and it's no longer working as a pump. The heart may stop working for other reasons as well. Now you see here that it's rhythmical, the electrical activity looks good, it's beating mechanically to pump that blood around the body. But sometimes it misfires and we get all of this electrical misfiring that means it doesn't beat effectively, it doesn't pump, and it starts to fibrillate. And this is one of the rhythms that can also lead on to cardiac arrest. Now the priorities in a medical cardiac arrest are chest compressions to make sure that patient still has restored blood flow. You are taking over the action of the heart muscle of the pump. And also defibrillation. What you want to do is you want to restore the normal electrical activity. But actually what we do here is nothing compared to what the bystanders do. We can only offer any interventions if people have good pre-hospital care by the people that are with them when they arrest. And on that note, I think it's worthwhile showing you this.
My name is Billy Jones, and I'm going to teach you a lesson you'll never forget. There are times in life when being tough comes in handy. Say some geezer collapses in front of you. What do? We need a volunteer named breathing. It's all right. First thing you do is you check it out. Yeah, responsive, breathing. Always making noises like this. Then his heart start working, he's having a cardiac arrest. Look lively. First with 999. Then you do hands on your CPR. And no kissing. No kissing is watch. Lock your fingers together, knuckles out. Then push down, right on the socket. Push down 5 or 6 centimetres. That's about 2 inches off my knee. Push hard and fast, about 2 times a second. Likes to be a staying alive. Worried to learn it. Better a cracked rib than then kick in the bucket. Keep this up to the ambulance arrives. So don't forget, check him over. 999, push hard and fast, staying alive. It works. Hands only CPR. He ain't as hard as he looks.
So CPR is one thing, defib's the next.
Ask them to go and get it. Defibrillators are normally located in workplaces and public spaces like airports, shopping centres, community centres and train stations. They may be labelled PAD, Public Access Defibrillator, or AED, Automated External Defibrillator, and anyone can use them in an emergency. The defibrillator will assess the heart rhythm and will only take to shock them if they need it. Shock advised. So you can't do any harm by using one.
So that's the important thing. What people do in the public when people suffer cardiac arrest is dependent on the people that are beside them at the time. And that's how we get survivors like Christian Eriksen, Danish midfielder who you'll remember arrested on the pitch in the Euro 2020s, and Fabrice Muamba, and that was back in 2012. So that's the important chain of survival. That's what makes survivors. And we only come in and can make a difference in a certain few number of cases. So that few number of cases is resistant ventricular fibrillation, when that heart just won't restart after electricity. Well, what can we offer in these circumstances? Well, we've got these special devices. This is a Lucas, which essentially is a machine that takes over chest compressions, so it doesn't fatigue like a person might. We do have a number of drugs on board that can help restore a normal heart rhythm. And we also offer some alternative defibrillation strategies. We know now that adding an extra set of pads and using double synchronous or simultaneous external defibrillation can have improved outcomes. You can also insert invasive femoral arterial lines and target adrenaline rather than giving it blindly, aiming for a diastolic blood pressure of over 40. Looking towards the future, actually some services already offer this. This is ECMO. ECMO stands for external corporeal membrane oxygenation, where essentially you plug in the vessels to a machine that takes over the function of the heart and the lungs. So it acts as the pump, but also acts as the oxygenator. And this is a photo in Paris of somebody being put onto ECMO at the side of a train. Equally, there's another shot of somebody in Le Louvre who survived after having ECMO for cardiac arrest in the pre-hospital environment. So let's look at trauma now. So trauma, as we've said already, it's the principal cause of life lost in young people. But more than that, we also know that up to a third of trauma patients have preventable causes of death. Now, this is an old paper. It's pretty seminal, though, because 4 pathologists looked at 1,000 consecutive trauma deaths and reviewed them to see if any were preventable. Now, up to a third of them were preventable deaths. And they were preventable mainly for the reasons of stopping bleeding, but also for treating low oxygen levels, and additionally for delays in definitive surgery. Now, that as a pre-hospital team are all things that we should be able to assist in to prevent those preventable deaths. So how do we do it? Well, the first thing is scene safety. So we have one patient, we don't want two. Nobody is compromised on the way to a patient. If you ever see a patient involved in an accident, your safety is the priority. Please, if they are compromised or you are compromised by trying to help them, don't be afraid to move people. People have traditionally been very worried about extracting people from vehicles for fear of causing injury. That is not a thing. Get them out, get them safe, make sure you're safe. We then take, we call it a CABC approach. So the biggest killer of patients is bleeding, so that catastrophic hemorrhage is always first. And then we move on to dealing with their airway problems, their breathing problems, and then once again reassessing for circulation. We perform the life-saving interventions as we find them, and clear communication at scene and to control is obviously important because it's about forward thinking where this patient is going to be dealt with best, where they're triaged to, and how they're transferred. So one of the things that we do is analgesia and procedural sedation. Now that is a simple humanitarian requirement. If somebody's in pain, we want to make them better. But more than that, it also helps with their rapid treatment and extrication. There was one patient I went to who was trapped in a vehicle, and unfortunately their family member was dead beside them, but they were crushed because of the steering wheel crushed, and they had bilateral thigh fractures, bilateral femoral fractures. The fire crew wanted to get them out, but every time they moved anything, they'd scream in pain and they'd stop. And that's kind of a normal response, but is not helpful in any way to getting them to definitive care. So actually, by good analgesia and good procedural sedation, we can manage these patients better and get them earlier treatment that they require. We also perform pre-hospital anaesthetics, so putting people to sleep on the roadside. And we do that for airway compromise, like the video you saw before, but also if their breathing is ineffective and they've got ventilatory failure. Furthermore, if somebody's got a head injury and they're unconscious, that would be an indication. Furthermore, for the humanitarian needs, sometimes in a very difficult, stressful, emotive situation, it may be the best thing to get them out of that situation. And then anticipate a clinical course. Are they going to get to theatre faster if they're put to sleep now, or do we wait until they're in hospital? Now, some of these anaesthetics can be a little bit more hairy than what we see in the operating theatre. It can be raining, it can be dark, there can be a lot of motion and people on scene. So we are very structured in our approach and we simulate a lot. We have a very specific technique with a lot of preparation and also a checklist that we use. Now, a bit like David Beckham when he goes to repeatedly take his free kicks or penalties, it becomes a motor skill if you use the checklist. It engages the team and makes sure that you've got everything available that you need, but it's also your comfort blanket, that by going through this, you can deliver this procedure with success. Now, we use a very simple drug regime that we tailor to each patient, but largely that's fentanyl, so a strong opiate, ketamine we use a lot in the pre-hospital environment, and then a muscle relaxant called rocuronium. Just to add a little bit more pressure to the situation, if somebody needs a pre-hospital anaesthetic, then we need to give it to them within 45 minutes of the initial 999 call time. And you can appreciate the barriers that we have to get there. That call has to be seen by the paramedics, they have to dispatch us, we have to get there, extricate the patient and deliver the anaesthetic within 45 minutes. But you'll also see that that's even harder if that were to be in a hospital. And that's once again why we exist as a pre-hospital team. We perform anaesthetics in about 25% of our cases, and we know that we can do it and do it well. 99% of cases of success, and any rescue attempts were all successful. Moving on to breathing. So a bit more anatomy now. On the left is a normal lung. You'll see it's inflated and it's got a pleural cavity, a pleural space. Sometimes with injury, the lung can collapse, known as a pneumothorax, or most commonly a collapsed lung. And you'll see that now that lung is collapsed, it isn't going to be very good at giving your blood oxygen. But also, if the pressure in that pleural space now increases, that can cause a pressure effect that stops the heart being able to beat any blood around. So what we need to do is we need to let that air in that pleural space, that pneumothorax, out in order to let the lung re-expand. Now, traditionally, what we were taught is that you should put a needle in the mid-clavicular space, so midway on your collarbone, 2 rib spaces down, and it would relieve the pneumothorax. But you'll see here that hasn't got a chance. All right, so we don't do that anymore. We tend to go in at the mid-axillary space, and we tend to use thoracostomies. So we blunt dissect down to the pleural space to open the cavity in order that the trapped air escapes. And this is really important because one of the fundamental philosophies behind the operation is to maximize oxygen delivery as early as possible. Bleeding. So bleeding is the top cause of preventable deaths. We say 20% of people could have survived had they had their bleeding controlled. So where do we bleed from? Well, we bleed onto the floor, so something obvious, like a wound in the leg, and 4 more. So you bleed from your chest, you bleed from your abdomen, you bleed from your pelvis. Now, Our circulating volume of blood is about 5 litres. The pelvis will bleed until it tamponades at between 4 and 6 litres of blood. So you can bleed out through your pelvis really quite quickly. Equally, each thigh bone, each femur can contain 1.5 litres of blood. So you can really do yourself some damage by any of those things. So what do we do about it? Well, the first thing to do if you see someone bleeding is press on it. Pressure will stop that bleeding. You can tourniquet above it, and then we also pull long bone straight into an anatomical position to stop the bleeding and put a binder on the pelvis to realign the anatomy, and that also stops bleeding. But going on from that, we will give people blood. So we declare what we call is a code red. So in the context of somebody bleeding who's got a low blood pressure and suspected or visible active life-threatening hemorrhage, or if they're in traumatic cardiac arrest, then we give them blood. We carry 4 units of blood and 4 units of plasma, and we give it warmed. Cold blood doesn't have any oxygen carrying capacity. It doesn't do us any good. So we carry these warming devices that have a battery pack that allow the blood to be heated and given at body temperature. There you go. It's nifty, it's designed for these pre-hospital services, and it's very effective. Now, in some circumstances, although thankfully this is rare, we may be expected to do an amputation, and that would mainly be if somebody is physically trapped by their limb with a no chance of release or extrication before they might die. And they might die because either they're exsanguinating from the limb, or it's time critical, the building's about to explode, so there's environmental risks. We obviously give them sedation to do that, and we have the equipment on board to safely carry out an amputation. Now, looking to the future, this is one of the services we may offer but currently don't, but this is called REBOA. So it's resuscitative endovascular balloon occlusion of the aorta. Now, classically, these are cyclists. They're cyclists who are on the inside of a lorry. The lorry doesn't see them, it turns left. It knocks them over off their bike, and then with the back wheels runs over their pelvis. So they get a massive pelvic fracture, huge bleeding. The other instance we may need this in is for, well, what they call in London bagging, where people are stabbed in the bum. That's a vessel that you can't press on. It's a non-compressible junctional vascular bleed. So what we do in this situation, or what may be offered, it's currently being trialled at the moment, and that's why I say maybe, is you put a balloon into the major blood vessels that goes up into the aorta, that's the big blood vessel coming out of the heart, inflate the balloon, and then essentially that stops any blood flow below it, so acts as a tourniquet. You can see from the image on the right that there are 3 zones of REBOA, depending on where the injury might be. Now this is Victoria Liebrecht. She is a survivor after having a REBOA. She's 24, or was 24 at the time, and she was in London as a student and got knocked over by a lorry in the way I've described earlier. And she has lost a limb, but has lived to tell the tale as a result of REBOA. Equally, we offer secondary brain injury prevention. If you have a head injury, the initial injury has caused the damage, but what we want to do is prevent any further injury or damage. So for those types of people, we put them off to sleep with an anaesthetic. We can control their blood perfusion to their brain, and we can target what blood perfusion that is depending on the other injuries they have. Equally, sometimes when the pressure becomes so high in their brain that we need to try and reduce it, we have medications on board to help with that as well. The most important thing I think that we do is get them to their definitive surgery sooner. Now this is an old study, but it's an important one because it shows that outcomes with people have an extradural hemorrhage, a bleed in their brain, the difference to their outcomes depends on their time to intervention. So 0.7 if you get taken straight to a neurosurgical centre versus 3.2 if you go via your local hospital, but the mortality and morbidity differences are enormous. Okay, so we need to get them there, and we need to get them there fast. Time is brain. So we've talked about medical cardiac arrest, the reasons that your heart stops, it goes into arrest because of the medical reasons, but also there's traumatic reasons. Now, it's a bit of a conceptual leap. In this case, your heart hasn't stopped because it's gone into a funny rhythm, or it hasn't stopped because it's had a heart attack. It's stopped for a different reason. It's either stopped because there's no blood in it to be pumped around the body, or because your oxygen levels have been compromised and are so low. Or equally, your heart's trying to beat, but it's beating against an obstruction, that being a tension pneumothorax, so a collapsed lung, that means it just can't beat against the pressure, or a tamponade. So we'll come on to have a look at tamponade. So in traumatic cardiac arrest, we don't put the same, we don't insist in the same way on chest compressions as we do in medical arrest. That doesn't mean they're a bad thing. It just means there might be more important pressing issues that we need to do at the time. And actually, sometimes chest compressions can get in the way of things that are going to take these patients out of arrest. So there's no harm in doing them, but sometimes we need to prioritise other things. So one of the most gory things that we do is for tamponade. So what do I mean by tamponade? Well, the heart sits in a sac, it sits in a pericardial sac, and if it's had an injury, blood can accumulate in that sac. That means that the heart is trying to beat, but it's obstructed. Nothing can be released because it's beating against an obstruction. So in this situation, we can do a clamshell thoracotomy, and we do this at the roadside. And the idea is essentially that you open the chest to reveal the heart, to open the pericardium, to deliver it, in order that you release the blood that's compressing the heart. You'll see on this picture as well, there's a hand in there, and what that hand is doing is pressing against the aorta. Now, the aorta is once again the big blood vessel that releases blood from the heart to the rest of the vital organs. And the importance of that hand is that your blood flow is then prioritised to your brain and your heart itself, so that any blood is prioritised to getting to the most important places. We do it mainly for penetrating chest trauma. So if somebody's been stabbed in the chest, that has the better outcomes, but also sometimes for blunt chest trauma. So if somebody has been in a road traffic crash, you get there and they're alive, and then they decompensate in front of you, but the mechanism is blunt trauma, not penetrating, then we do it for that as well. Now, there's a number of reasons that we do it for that. So blunt trauma doesn't mean there's not a penetrating mechanism. So if somebody's had blunt trauma, they could still have a penetrating cause of tamponade by a fractured rib, for example, that's then pierced the heart. But also what we can do for the blunt trauma thoracotomies is compress the aorta, so they can't bleed below that point. They can't get any blood below, so none of their abdominal organs should bleed, and not their pelvis shouldn't bleed. And once again, the blood that you're refilling them with can be prioritised to go to the heart and the brain. How do these patients do? Well, actually, this London series showed that there are 18% of them who had thoracotomies, so they were dead at the roadside and had clamshell thoracotomies. They survived to hospital discharge. And the neurological outcome, which is obviously what you want to be good, was good in 85% of cases. But you'll see there that the critical thing is time, right? They have to have this intervention soon, and it has to be done quickly. So we know that any poor neurological outcome or survivors are more likely to happen if the time frame is longer and it's not done quickly. One of the other more gory things might be a resistive hysterostomy. So this is for mums who are in late pregnancy. They're obviously pregnant. They're very unstable, their heart is about to stop or has stopped. Then actually the best chance of survival for the mother and for the baby is to deliver that baby. That is once again time critical, should be completed within 15 minutes. Now we do it very differently than they do it in elective sections, and that's to allow easy, quick access to people who don't do this as part of their day jobs. I am not an obstetrician, this isn't my normal day job, but this is something that we are expected to be able to deliver in a critical environment. So, what are the challenges? Well, the challenges are the place that we work. The environment is in Britain, so it's somewhat abhorrent weather most of the time. Scene safety is always a big issue. Sometimes we're first on scene and the roads haven't been closed. But also the environment can be hostile, it can be emotionally charged, especially if relatives are present and friends are present. And now we have a lot of people taking bystander video footage, which can be disruptive. We are expected to communicate through the radios to let people in control know what we're up to. Equally, we are resource limited. There is 2 of us in a tight-knit team expected to do the job of many people in a theatre. And we're also multiple agency. And there are often people, in fact, mostly people that we've never worked before, from fire, police, and mutual aid. There can be a lot of human factors involved at scene, a lot of people wanting to take charge or having different views about where this goes. So it's very important that you all get onto the same hymn sheet and communicate clearly. Plus, the patients tend to have their agenda of their own. They present with different mechanisms of injury, from road traffic crashes to shootings, stabbings, and then the medical side of things as well. There are diverse patient groups, some very young, some very old, and some very multiple. And they have rapidly evolving pathology. You think they're okay one minute, and then they're not the next. Equally, we don't have the same access to scans as we do in hospital, so a lot of it is based on our clinical acumen, and we have to consider where these patients are best treated very carefully. And then add to that, we've got lots of time targets as well. So we should be delivering antibiotics sooner, we should be giving tranexamic acid, which stops them bleeding, within 3 hours, giving a pre-hospital anaesthetic within 45 minutes of the 999 call, and then obviously the thoracotomy and the hysterostomy within 10 and 15 minutes of arrest. And then we've got to get them to hospital as well within that 60 minutes. So there's a lot of things that we have to do and aim for, and that's why it needs to be slick. But do we make a difference? Well, actually, we kind of have to prove ourselves, right? So there's a number of studies, but these 2 I quite like. So it does show that compared to our paramedic-only crews, actually we don't have any longer scene times. We don't stay and play, which was the initial fear. And all of the advanced management we do doesn't take any longer than the less advanced management that the paramedics alone could do. And there's evidence as well to show that for every 100 times a helicopter is dispatched, we can save about 5.3 lives. So you might be thinking, well, how can I make a difference? Well, if you fancy considering the Northwest Air Ambulance as your charity, then that'd be great. But also, if you fancy attending a life support course, then you might be the next bystander that really does save someone's life. But also, there are 2 apps that I strongly recommend or highlight for you. And one of them is Good Samaritan app that was developed by a guy that I used to work with in London. And this is as an alerter for somebody who's gone into cardiac arrest, or if you want to be a responder to respond to somebody who's been in cardiac arrest. It's got vital information on it, like where your nearest defib is, in order to be able to respond and deliver that treatment early. And then What 3 Words is a great app, and what that does is allows you anywhere in the world to be identified within 3 words. So every location that you're in will have a 3-word identity, and when you don't know where you are, it's really important that the ambulance can get there to you in the fastest time possible. And that helps. And that is a wrap.
Absolutely fascinating. Do we have any questions? We've got time for some questions. Yeah.
I don't have a picture of how you do this. Are you at home?
No. So we're based in Barton. Essentially we start our shift at 8 o'clock in the morning, or 7:30 in the morning, and we arrive at base in Barton, which is, as I said, just by the Trafford Centre, and we are at base waiting to respond to any 999 calls. So there's a pilot there, there's a paramedic there, and there's a doctor there.
And how far out to sea do you go if, as the first bit of film indicates, you might have a maritime?
Yeah, well, I mean, fortunately, on an aircraft, anything we can cover distances quickly. We could be there in 20 minutes. But that is one of the challenges of the service, is that we have one aircraft with a doctor and a paramedic, and obviously we have to think about where that's best based. The cities are one of our most commonly visited places. The rural districts less so. Actually, in the Lake District, it's more likely to be things that can be attended by the paramedic crews. So fractured ankles on a hillside, which is just an access issue, is something that they might go to.
So there's no procedure which limits the distance that you can travel out to sea?
We don't go out to sea, so we're only land-based. So Dave had his injury coming back in from sea. But we've also got neighbouring air ambulance services as well. So the Newcastle service responds to the other side of the lakes and over, obviously, to Newcastle, Sheffield.
So you say in the cities, let's say Dale Street, Liverpool.
Yeah.
Do you have issues as far as landing?
Well, absolutely. And that's one of the reasons. Well, you find somewhere as close as possible and hope to holler a lift. But actually, sometimes what we do is find the nearest open space that you can safely land. Safely landing means 2D, when you can visibly see, so that's 2 times the diameter of the rotor blades. If you're night flying, that needs to be 4D, and that's one of the restrictions why we don't night fly, because actually in built-up areas, you very rarely get those places. If it's during daylight hours and it's a remote drop, then we'll actually ask the police to come and meet us and then give us a lift to the scene.
Yeah. Clearly your medical training is way up there, but do you get extra training because you're on an aircraft?
Yeah.
Normally if you on a helicopter, you have to do the helicopter escape underwater business. What extra training do you have to do?
So as a doctor, we are a medical passenger. We are not involved in the navigation. They've not given us that responsibility, and I'm very grateful of it. And the paramedics do have additional training. They are involved in the nav. They are second in command. But as a doctor, we have our basic competencies that have to be signed off every 3 months, and that's basic aircraft safety, but we are a medical passenger by all accounts.
Okay, so can I just ask you, I mean, the kind of prioritisation, so you've got somebody in a road traffic accident who's got blunt trauma to the chest and they're bleeding from the leg, and you've got to make those decisions really fast about what your priority is for that individual. Do you presumably you have a standard way of going through that?
I think my standard mantra is, what do I think is killing this patient first?
And that's a judgment.
And that is a judgment call. But you work very closely with a paramedic, and by vocalising what you're finding and how you're dealing with it and the response to those interventions, I find is the way that we work.
And do you find most of the time as a team that you agree quickly?
We've got the same priorities. We're singing from the same hymn sheet because we train a lot together, and it's very rare that you're on different pages.
That's good to know.
Yeah.
Enjoyed that a lot, Gemma. Really nice delivery. I'm going to just push you a bit on the resuscitative thoracotomy.
Yeah.
Which has been.
You promise no difficult questions.
Controversial for quite a long time, and there are less than 1 in 5 patients who walk out of hospital. You're an anaesthetist.
I am.
A skilled anaesthetist. You don't have a surgeon on in the cab. Just talk us through the sort of futility of the decision making about opening someone's chest at the roadside, which is a huge thing to do.
Yeah.
And your criteria for doing so, and for not doing so. What position you're in when you're declaring somebody dead, and that really difficult decision, I'm going to give it a go. It's hugely difficult. I know it is.
No, it is absolutely difficult. We know that to do a thoracotomy and for it to have good outcomes and good neurological outcomes, and I think that is the most important thing. Nobody wants somebody to survive with a brain that's not. We know that time is the most pressing issue. So if my approach is to get as much information before we get there as possible, I'll find out the 999 call time. I'll find out the time that we have been told that they have lost their output. And I'm then armed with that information before we get there, because that helps with the decision making. Equally, I have the same response if somebody's coming into A&E and the decision is to do thoracotomy or not, because some people, I think, have it far too late and it's not going to be a good outcome. But once you've made that decision that this is the right thing to do, then actually you have to let yourself crack on with that decision. Otherwise, you get decision paralysis and you don't perform the procedure well because you're doubting yourself. So then it's that motor skill again. It's something you've rehearsed, it's something that you've taught, it's something that you've trained for, it's equipment that you're familiar with, and you have to have that strength of courage and responsibility in order to deliver it. Equally, that patient is dead. You know, they are not going to be more dead. And the best chance that we've got of them surviving is by delivering this and delivering it quickly with the best intentions.
Okay, thank you for that.
More hands, more hands!
So, the lady in red, and then I think Chris is the last one.
Very naive question. Why on air are you a charity? Why is that not recognized? Why is your work not recognized as part of?
I mean, it's a question that we also ask. I don't have an answer. We've gone, you know, government do recognise us, and they do, you know, Prince William is one of the patrons of the Air Ambulance charity, and we, in the budget, always get a donation, but actually our work is not paid for by the NHS or by government funding. So it does rely on donors.
Chris.
I was going to follow up the question on my mind, and that was, how many times have you worked on the chest?
5.
And with what degree of success?
We got 2 of them to hospital, 2 of them to theatre, and then unfortunately they didn't survive until out of hospital. We're doing about 1 thoracotomy a month in on our service, and we've had 3 survivors.
Well done.
Final question, maybe here.
Do you have a sort of debrief system, or afterwards do you get mental health support for the charity? Because this all sounds horribly stressful.
Yeah. We do have a debrief system. We have a trim system as well, that people who go to particularly challenging jobs may be flagged up and just being put the phone call in, are you okay? So we do have those channels to access. We try and debrief all jobs as a hot debrief, and then we've got an opportunity, we call it D&D, Death and Disability, or Death and Donuts, meeting that we attend to go over the jobs again. What you don't want to do is put people under undue pressure thinking they've made mistakes and they have to relive it in front of an audience, because I don't think that's good for anyone. What we want this to be is a learning opportunity, not something that punishes them. Sometimes, however, the job just gets in the way, because you've gone to one job and then you've been bounced to another job and then again to a third, and then it's the end of shift, everyone's tired and you're late and you want to go home, and then you might not see the same team again for a while. So that is definitely one of the challenges, and something that we try to be good at, but we don't always get right.
Fantastic. I think probably we have to go on.
Thank you very much.
Yeah.
I too should like to congratulate Gemma. Fantastic talk. It was really very, very good. I remember when you went off and did some training. Do you ever find that, you know, for this helicopter service, do you ever find you're short of medics?
No. Funnily enough, we have a lot of people that are very keen to train. I mean, it's only recently been recognised as a service itself. You know, it's pretty new in its establishment, and only recently does it have its own college, faculty of pre-hospital medicine. But we are pretty oversubscribed for people that are keen and interested. And we need a lot more, you know. We have a service that doesn't run 24 hours a day. We have a service that runs from 8 in the morning till 8 in the evening, and a bit more on Fridays and Saturdays. But actually, that's because that's all we can fund at the moment, and that's all we can staff at the moment. But looking forward to the future for resilience in the system and for developing the system, then we do need more.
Thanks. Fantastic. Well, thanks. Well, just so that when we do finish, everybody be very carefully driving home.
Yes. Yes, do that.
Okay. Thank you very much, Gemma. That was absolutely fantastic. I'm just going to hand over to Nigel Cunliffe, who's going to just give the vote of thanks from the Liverpool Medical Legal Society.
Thank you. It's comforting to think that when I next run up Helvellyn, I fall off the top and break my ankle, that an hour later I will look up and I will see this whirly bird in the sky, Gemma smiling down. All I ask is that if I've only got a sprained ankle, don't open my chest. You may want to practice on me, but please resist the temptation. I was interested in the question from the audience, which is the one that I suspect is in the mind of everyone. Why isn't this part of the NHS? I mean, it's got to be part of it. There we are, that's the country we live in. And I shall shortly be moving to France, where I'm sure things are much better. It's not that easy. Gemma, thank you. You put work and effort into that, and you prepared a lovely presentation. So thank you very much for keeping us informed and entertained. Keep up the good work, that's all I can say. And continue, as we all will, going to the Lake District, risking falling off mountains and the knowledge you're there to help us. So thank you very much indeed. This is a promotion for the Medical Legal Society, in the hope that their president has finished his Zoom call with 5 solicitors, 5 experts and 2 KCs. Can I, in his place, announce on the 10th of May, it'll be at the Athenaeum, we have a talk on the Pembrokeshire Coast murders. So those of you of a gruesome disposition, which is 98.7%, I have to plead ignorance. I don't know what the Pembrokeshire Coast murders are, but I'm sure that lots of people do. It'll be very interesting. The officer who was in charge of that investigation, Steve Wilkins, will be giving us a chat. So you're all welcome. And if you forget the date, the 10th of May, you'll always find it on our website. Thank you very much.